everyone, and welcome to the AORTA Symposium in Brazil. I'm Laura Hawkins. I manage Cook Medical's endovascular planning service in the Americas, where we collaborate with physicians worldwide to develop patient-specific endovascular solutions for aortic repair. Today I have the honor of being joined by Professor Bijan Modarai, a distinguished figure in the field of vascular surgery at King's College London and Guy's and St. Thomas's Hospital. Professor Modarai, thank you for joining me.
My pleasure. It's a real pleasure to be here.
Thank you. I am aware through social media that later in the year, you're organizing a meeting on aortic dissection. Is this a specific area of interest to you?
Oh, absolutely. I mean, I think dissection is a fascinating disease. You know, no two patients are the same almost. The diagnosis, management, including the intervention that's required for these patients is unique per patient. So this meeting that we're holding on September the 6th at Bush House in London, if I can get that plug in, is called the Interdisciplinary Aortic Dissection Symposium, and it leverages a group of distinguished speakers from various disciplines to talk about this disease condition. So it promises to be a really exciting event for an exciting disease process.
It will be an excellent event where we can appreciate even more insights into this disease. Speaking of dissection, most dissections present acutely. Can you share some key points about managing those patients when they first present?
So, I mean, I can perhaps talk about the UK. There's been a lot of work going on to the patient pathways pertaining to this condition. So key is recognizing that these patients have a dissection early, instigating appropriate imaging, and then transferring these patients to aortic centers where you have this interdisciplinarity that I mentioned. So, you know, you have your cardiothoracic team, your vascular surgical team, the appropriate medical team to manage the medical side of the condition, and, you know, diagnosis, so prompt imaging that's required to know exactly what kind of disease process you're dealing with per patient.
Mm-hmm. That's a crucial aspect of managing such emergencies. Can you elaborate on how your hospital leverages expertise through this multidisciplinary approach?
Yes, so we are one of the largest aortic centers in the UK. So the patients are processed quickly in the emergency department, so they receive the imaging that they need. And then I think one of the advantages we have is the close working relationship with the cardiothoracic surgeons. As you know, dissection can involve pretty much the entire aortic tree. And so if the disease process involves the arch and the ascending aorta, we have that dialogue quite quickly with our cardiothoracic surgeons and they manage the patient. If not, then the patient comes to us and we manage them appropriately. As you know, a large proportion of patients are managed medically, so you need the appropriate intensive care support, the appropriate medical support. We in fact have a dedicated hypertension management team, and as you know, hypertension is managing the hypertensive patient, which is often the case where the patient presents, is key in the initial management period to get optimal therapy. So it's all about having all of those individuals in place. It's a team game, managing dissection. It's a team endeavor.
Thank you. So dissection is a long-term condition, with the aorta dilating over time, and these can be particularly complex cases. Will you share your approach in managing chronic dissections?
Yes, so again, you know, it's a lifetime commitment for both the patient and the surgeon when they first present with acute dissection. And I think when we manage the patient acutely, when we intervene on the patient acutely, we need to be cognizant that we will be back when the dissection becomes chronic. So, you know, it's about making sure that the initial intervention plans for the subsequent interventions. So how do we set ourselves up for example, stent grafting the rest of the aortic tree when it becomes a chronic dissection? Does the patient need a frozen elephant trunk when the cardiothoracic surgeons intervene? We must be careful not to burn bridges by occluding collateral supply to the spinal cord, so the left subclavian artery or the internal iliac arteries. And, you know, once the patient is on their way to become a chronic dissection, we need appropriate pathways in place to perform serial imaging and to review that imaging to decide when that chronic intervention is needed.
Interesting. So you mentioned three options in discussion: medical management, open surgical repair, and endovascular repair. Could you focus a bit more on endovascular repair? There are various techniques available for aortic repair, and Cook offers dissection-specific and patient-specific solutions in this area. Can you share your thoughts on these?
Yes, so should we break it down into acute and chronic? So in the
Okay.
acute phase, I think that there's a nuance with stent grafting acute dissection because the most feared complication is type A conversion. So if you land a stent graft in the distal arch, and then that converts that arch into a retrograde type A dissection, that carries a bad prognosis for the patient. So Cook manufactures a stent graft that has no barbs or bed stents in the proximal section. And there is some evidence to suggest that bare stents in particular can increase the rate of conversion to type A dissection. So I think it's worth bearing that in mind when choosing your stent graft. Cook also manufactures a bare stent, which can be used distal to your covered stent graft if the proximal intervention with a covered stent graft is not enough to open the true lumen and restore flow to the visceral and renal vessels. So again, that's in the acute toolkit. For the chronic phase, it's all about occluding the false lumen, isn't it? So the acute phase is more getting the patient over malperfusion, but the acute phase is about occluding the false lumen and positive remodeling of the aorta. And, you know, we can talk about branched and fenestrated stent grafts to extend your distal seal with endovascular repair to effect false lumen occlusion, or the false lumen endograft, which sits in the false lumen just above the celiac artery to prevent retrograde flow into the false lumen and again cause false lumen occlusion. So lots in the portfolio.
Yes, thank you. And as you mentioned, this disease can affect the entire aorta from the arch to the iliacs. Can we focus proximally, landing in zone 2, and your thoughts on preserving the LSA?
Yeah, so again, you know, as I said, it's a lifetime commitment, and often patients can end up with total aortic coverage, and of course, with that, the risk is spinal cord ischemia. So, and the collateral flow to the spine includes the left subclavian, of course, and particularly in the acute scenario, I think it's important to preserve the left subclavian artery if we can. But in the chronic scenario, I think there's no reason not to preserve that collateral flow. And devices such as the left subclavian branched or fenestrated endograft really do increase our options. You know, carotid subclavian bypass is of course an option that's been traditionally used, but that's associated with quite a lot of local wound complications, nerve injuries. So if you have an easy way to endovascularly preserve the left subclavian artery, you're more likely to do that. And the Cook retrograde left subclavian branch device, I used that recently and it performs very well. Of course, there's the option for the fenestrated endograft to incorporate the left subclavian. So I think it's all about leveraging the entire endovascular toolkit that, of course, Cook has available.
Between the fenestrated and branch option, do you have a specific approach in deciding which is best for the patient?
Well, I think if the anatomy is suitable for a retrograde branch, and I think we have enough evidence now to show that flow through the retrograde branch is not compromised, that would be my preferred option, providing that retrograde branch allows enough proximal seal. You get less problems such as wire entanglement, the cannulation of the left subclavian easier with the retrograde branch. You don't necessarily need a left brachial through wire. So if possible, I would always opt for the retrograde left subclavian branch.
Thank you for sharing. Now let's extend distally. What is your approach for landing distally above the celiac trunk in the descending thoracic or extending through the visceral segment?
Yeah, so I think again, you know, we've learned that endovascular approaches to the aorta are best done in a staging manner. And this speaks to promoting false lumen thrombosis. One of the devices that we're using more and more is the false lumen endograft. So again, for the audience, that's essentially a plug that sits inside the false lumen, just above the celiac artery and adjacent to the thoracic stent graft that you've placed inside the true lumen, and that prevents retrograde flow of blood from the abdominal portion, entry tears in the abdominal portion, back into the false lumen. And that doesn't burn any bridges. So our threshold for using that has become lower and lower. So when you place your endograft, you can place the plug in the false lumen. Now, if that then doesn't work down the line, that doesn't stop you from using a branched or fenestrated endograft to extend the seal distally into the common iliac arteries. Of course, in some patients, the false lumen is quite big, and the false lumen endograft is not an option, in which case you might opt for a branched and fenestrated solution to extend the seal in the first instance.
Thank you for sharing. And you mentioned branch and fenestrated. With Cook's patient-specific devices where available, we have the option to do fenestrations, internal, external side branches, and inner branches. And what would be your preferred choice for these dissection cases?
Yeah, so I think traditionally there's been the impression that the true lumens often collapsed and compromised, and so we ought to opt for fenestrated solution as much as possible through the visceral segment and renals. But I think we've realized that particularly when there's a gap between the main aortic stent and the origin of the target vessel, if you have to bridge a longer distance, you get more likelihood of target vessel instability over time. So, and the true lumen diameters are often bigger than you think, particularly when the entry tears are sealed, and that affects true lumen expansion. So more and more we are likely to use branched endografts, perhaps coupled with a septotomy to increase the luminal diameter, because you then avoid that longer bridging distance with the fenestrated solution. But I think it's all about leveraging graft design, and again, it comes back to each patient being different and a bespoke approach to each patient. So liberal use of branches when there's a big gap, otherwise fenestrations. And again, when you go more distally, as you know, the dissection can often affect the iliac vessels, and therefore in a patient that has total aortic coverage, I will do whatever it takes to preserve internal iliac arteries, because that's collateral flow to the spinal cord. So ideally, using an endovascular approach with the ZBIS, the iliac branch device that Cook has, even with open surgery, if the patient's not anatomically suitable for an endovascular approach, come what may, you have to preserve the entire collateral blood supply to the spinal cord.
Yes, we're treating the disease, but we also want to be cognizant and plan for the quality of life for the patient after these repairs. Speaking of long-term, let's get into long-term care. What is your medical management and imaging strategy for these patients?
So I think we need to make sure that when we discharge these patients to the community, they're managed well. Because even though they may tell you that they take their antihypertensive medications, compliance can be poor. So the way it works in our hospital is they are seen by our hypertension team. So we have a specific hypertension team, because obviously the key priority in the medical management of these patients is to keep the blood pressure low so that the aorta doesn't go on dilating. So they see the hypertension team, and then they are discharged to the community. And then they are reviewed again by the hypertension team to ensure that they are compliant. And as I mentioned earlier in our talk, I think it's important to carry out regular imaging to make sure that you are one step ahead of the dilating aorta, so to speak, so that when you need to intervene, you can. So they have initially early CT scanning, so perhaps a month after discharge, and then perhaps 3 months after discharge. If you see that the aorta is stable, then I increase those intervals to a year, perhaps sometimes 2 years, because remember, these patients are often quite young, and radiation exposure can be a problem.
Thank you for sharing. And let's look ahead. How do you envision the future of aortic dissection management to evolve?
So we've got 3 really exciting trials starting, which will be a feature of the dissection meeting that I'm putting together. The Earnest trial in the UK will get going soon. The Sunday trial in Scandinavia, and the Improve AD trial in the USA. So all three trials are aiming to answer the question of whether, when the patient presents with acute, uncomplicated dissection, we should be sending them early down the line to promote better aortic remodeling. So once we have the answer to these trials, which are a few years away yet, that might potentially change how we approach and manage dissections. I think that the advent of artificial intelligence and being able to scan, to be able to analyze, CT scans at scale will allow us to decipher better early markers from CT scans of patients that may develop problems later on after they initially present with their acute dissection. So it's all about informing this nuanced management of each patient using big data, if you like. So I think that will be the big revolution in the 5-10 years to come.
Yeah, we're all excited to hear about those outcomes. Well, thank you, Professor Modarai.
My pleasure. Thank you for having me.
Your valuable insights and expertise is much appreciated, and it's been a pleasure speaking with you today. Before we go, can you just leave us with 5 take-home messages about the management of aortic dissection?
Yes, of course. So the key, I think, is early diagnosis and interdisciplinary management. I think it's important to think one step ahead and realize that these patients are, this is a lifelong commitment to treating the patient, so don't burn any bridges. I think that preservation of flow to the spinal cord is very important, and that's a nuance that has to be borne in mind. The uncomplicated dissection trials will be very exciting come the future, and I think that imaging these patients will also develop as time goes on.
Very good. Thank you so much.
Thank you for
It's been a
having me.
pleasure. Thank
My
you.
pleasure.